Good morning, everybody. It's a pleasure and honor to be here and introduce Dr. Joe Decker for this talk this morning on atrial fibrillation. Quick thanks to Bridge Bio and Recor Medical and grant support from Abbott for this grand rounds. Dr. Decker joins us from the University of Minnesota. He's born and raised in the Twin Cities and born in St. Paul and did his undergrad, medical school, internship, residency, and fellowship at the University of Minnesota. And we are really proud to have him here as part of our group. It's not often that you hear about a EP fellow in their first year of fellowship, when most fellows are just learning to pick up a catheter. But you could kind of say Dr. Decker had EP in his DNA, and I'll talk a little bit about that. So prior to starting medical school, he worked at the Minneapolis Heart Institute doing research with Dr. Tim Henry in the Level 1 STEMI program. And then he was actually a EP lab technician. So his first EP journey kind of began at Abbott and brings him back to Abbott Northwestern. And Mirzak, one of our EP lab techs leads right now, actually told me that even at that time, Dr. Decker was just reading and thinking. You could tell something was unique about him. And he's got it in his DNA because his dad actually was an EP lab manager, then has worked with Biosense in industry for many, many years. So Dr. Decker went on to work at industry and then decided to go to medical school and become an electrophysiologist. And so his primary clinical interest is management of atrial fibrillation, including lifestyle and risk factor modification, as well as ablation therapy for AFib and other atrial arrhythmias. He's married and has 4 kids. It's really a pleasure and an honor to introduce him for his first of many grand rounds. So sure, so thank you. Welcome, Dr. Decker.
Thank you so much. Very good. Well, thank you for those kind words, Dr. Sengupta, and thank you guys all for being here today. So I'm going to be providing an update on atrial fibrillation management, specifically looking at the role of rhythm control. I have no disclosures related to the talk. These are the objectives. So first of all, I'll start with a brief review of the epidemiology of atrial fibrillation, then look at kind of the progressive nature of atrial fibrillation, look at some lifestyle modifications for reducing AFib burden, review rate versus rhythm control, specifically look at the role of catheter ablation for rhythm control, and then look at the most up-to-date management strategies, ablative strategies we have for atrial fibrillation. So in terms of epidemiology for atrial fibrillation, this is, AFib is the most common sustained arrhythmia. I realize I'm not breaking any news there, but the increase in prevalence of this condition is rapidly rising. So in 2010, the estimated prevalence was 5.2 million. That's expected to rise in 2030, 12.1 million, globally rising as well, so 50 million in 2020. The diagnosis of atrial fibrillation varies by multiple factors, socioeconomic factors, clinical factors, genetics, with different groups being at different risk. So, for instance, white males are at particularly high risk with a lifetime risk around 30 to 40%. It's hard to predict the cost of these complex conditions, but a recent paper suggested that the median annual direct medical cost per patient of AFib is over $13,000, with most of that cost being spent on inpatient care. So what accounts for this rising, this increase in prevalence as well as this high risk? Well, it's really it's a complex interplay between multiple different factors. So we have an aging population, we have new technologies, cardiomobile, wearable devices that allow for earlier detection of atrial fibrillation. These have led to an increase in primary care visits and referrals to cardiology for atrial fibrillation. And then there's also a whole complexity of chronic medical conditions that also interplay with atrial fibrillation. Obesity is one that's of particular interest to me. If you look at the prevalence of obesity and the rise there, it very much mirrors that of atrial fibrillation over the past several decades. So if you think about all those chronic medical conditions that drive AFib, it's easy to think of atrial fibrillation as a progressive condition. So this is a view of the posterior wall of the left atrium. These are the left-sided pulmonary veins, the right-sided pulmonary veins. And I just want you to take a mental snapshot of that because on the next slide you'll see how someone like myself sees the left atrium from more of a structural and electrical standpoint. But when thinking about how someone goes from, less than 1% burden, maybe minutes to hours to a few days, more a paroxysmal picture, to more of a persistent or long-standing persistent picture of atrial fibrillation, there's a number of structural and electrical remodeling and changes that occur in the left atrium. There's certainly dilation. Beyond that, there's altered ion channel expression, calcium signal changes, specifically a reduction in L-type calcium channels. Also inflammatory and interstitial changes, increased myofibroblast activity, collagen deposition, fibrofatty deposits. All these things create substrate to allow AFib to propagate. So this is how it may look to an electrophysiologist in terms of the progression. So again, that image I showed you on the last slide, the posterior wall left atrium, these are all that exact same image, but this is 3D electroanatomic mapping that we do in the lab every day. So this is one example of a mapping catheter. We basically use this multi-electrode, multi-spline catheter to move around the left atrium and gather not only detail about the anatomy of it, but also the electrical characteristics. So this is how, if you start here on the far left, this is how pre-atrial fibrillation may look, pre-AFib. This is a term that was used in the 2023 guidelines. These are individuals, perhaps they have a history of atrial flutter, maybe they have some mild left atrial dilation on echo, maybe an increase in PACs. They're at risk for atrial fibrillation, but they don't have clinical AFib. They have, just to give you some orientation here, purple is preserved voltage. So in other words, electrically healthy tissue. Red and the other sort of gradient of colors would suggest a reduction of the signal. So deeper into the pulmonary veins, it's normal to see low voltage, but you do see some sleeves of voltage entering into the pulmonary veins. Contrast that with paroxysmal atrial fibrillation. You can see this left atrium is more dilated than the one on the far left. You can also see you're beginning to see some changes in the electrical nature of the tissue on the posterior wall. Persistent is even more striking. So this is, clearly, this is a much more dilated left atrium and clearly more heterogeneous in terms of the electrical qualities of this individual's posterior wall. And then finally, long-standing persistent, this was a case I did in fellowship. This was a gentleman who had, years of atrial fibrillation. This was one of the more challenging AFib ablations that I did. This is a hugely dilated, severely dilated left atrium, and you can see, as indicated by the, a lot of the red, this is, a very sick left atrium as well. So we know atrial fibrillation is associated with a 1.5 to 2-fold increased risk of death. There's an increased risk of stroke that's guided very much by the CHADS-VASc score risk factors. There's an increased risk of dementia up to 1.5-fold, and there's a 5-fold risk of heart failure with atrial fibrillation. So given all these risks and this progressive nature, it's really critical to think how we can treat our patients as they make this transition. How can we help them feel better? How can we potentially slow this progression? And also potentially even have an impact on all of these risks that go along with atrial fibrillation. So in terms of what the expected rate of progression is from paroxysmal to persistent, this is a nice study. It's a Canadian registry, 755 patients. All of them had new paroxysmal atrial fibrillation. And it looked at the rate of progression over time, as sort of a natural history study. They found that at 1 year, almost 10% had progressed from paroxysmal to persistent. At 5 years, 24%. At 10 years, 36%. Several factors contributed to the progression of atrial fibrillation. Increasing age is one of the biggest. Valvular lesions such as mitral regurgitation, aortic stenosis, as well as structural changes, so left atrial dilation, left ventricular hypertrophy. These are all things that can contribute to someone's progression from paroxysmal to persistent. This study and others, and this is kind of sobering, but within 10 years, if you meet someone in clinic who has new diagnosis of atrial fibrillation, over 50% of those individuals will either progress to more persistent atrial fibrillation or die in that time period. So this, these graphs show this nice linear increase in, progression over time from paroxysmal to persistent, as well as an increased risk of death, increased risk of stroke, increased risk of bleeding events over time in these individuals. So We go into electrophysiology because we love working with our hands and certainly love procedures, but I would be remiss if I didn't at least mention some modifiable risk factors for slowing atrial fibrillation progression and reducing the burden. There's really a number of targets that we can focus on. So obesity, physical inactivity, alcohol consumption, as well as more traditional cardiovascular risk factors, smoking, diabetes, hypertension. Obesity, as I had mentioned, is one of my own clinical interests in terms of atrial fibrillation, and it's really quite complex, the interplay that has with the heart. So an increase in metabolically active adipose tissue will increase cardiac output. This will increase circulating blood volume, and it leads to a cascade of effects that affect, the ventricles and the atria. And so one of the things I did during fellowship was look at sort of this pre-atrial fibrillation population. So specifically looking at how changes in measures of obesity over time can affect atrial myopathy. Atrial myopathy is sort of what I had alluded to on that prior slide. This is structural and functional changes of the atria over time that increase the risk of atrial fibrillation. So to do that, I used the ERIC database. This is the Atherosclerosis Risk in Communities study. It's a study of 4 U.S. communities, including here in Minneapolis, as well as Maryland, North Carolina, and Mississippi. The individuals in this study have done multiple study visits over time, and we put our focus on visit 4 and visit 5. So visit 4 took place in 1996 to 1998, visit 5, 2011, 2013. So a nice time gap between these 2 visits where we included over 4,000 patients, none of whom had incident atrial fibrillation. And we looked at how changes, measurements of changes in obesity took place over that sort of long time stretch in these individuals. We looked at BMI, waist circumference, waist to hip ratio, measurements in the, that fit the variables of the metabolic syndrome in addition to the traditional BMI measurement. At visit 5, all these individuals had an assessment of atrial myopathy. So this is two-dimensional, they all had echocardiograms done with two-dimensional speckle tracking looking at LA strain data. And specifically, these echocardiograms measured LA reservoir strain, conduit function, and contractile function. So reservoir strain, this is, if you look at the figure on the right, as the left atrium fills and stretches, the mitral valve is closed, and with the peak of systole, you get your reservoir function. Now, as the mitral valve opens, there is passive emptying of the left atrium, and the early peak during diastole is your conduit function. Contractile function of the LA is pretty straightforward. That's atrial systole. So again, our goal was to look at how changes in all these measurements of adiposity over time contribute to atrial myopathy. So we used individuals who maintained consistently low measures over time as our comparison group. So in other words, individuals who kept a BMI of under 30 or a waist circumference under the levels that the metabolic syndrome uses to say elevated versus low. And compared to those to individuals who had consistently elevated numbers or went from, for instance, a BMI of less than 30 to above 30 and so on. And then we used multivariable linear regression to assess the association between those changes and left atrial function. And with pretty rigorous models here adjusting for things like age, sex, race, as well as cardiovascular risk factors, physical activity, and other echocardiographic measures, we found that those, compared to those who maintained low measurements of obesity, those who had either increasing or consistently elevated measures had worse LA conduit and reservoir function. So this table is an example of reservoir function as it relates to waist circumference. The figure here also shows this inverse relationship. As waist circumference increases, reservoir function of the left atrium decreases. So the finding here is suggestive that maintaining low measurements of adiposity over life does potentially play some role in preventing atrial myopathy, which may ultimately prevent atrial fibrillation. We also know that individuals with AFib do well with long-term weight loss. So this is a study with 355 patients, all with atrial fibrillation and a BMI of 27 or greater. And these individuals underwent, pretty nice, structured, motivational, directed weight loss. So this was face-to-face meetings. This was, meal plans focusing on low carbohydrate diets, low-calorie diets as well, all for the purpose of weight loss, as well as behavioral modifications, things like maintaining an activity diary. And then they follow these individuals over time, and they kind of categorize nicely into three groups. A group that lost 10% or more of their body weight, a group that lost around 3 to 9%, and then a group that lost 2% or ended up actually gaining weight. And what they found is that those who were able to have long-term weight loss and maintain it had a 6-fold greater increased chance of being free from atrial fibrillation over the follow-up period. And so this initial chart is ablation-free and drug-free freedom from AFib. And again, the red is those individuals who maintained or lost that weight and maintained it. If you combine that weight loss with ablation, with drug therapy, those individuals do really, really well. So certainly there's a role for weight loss and focusing on modifiable risk factors for atrial fibrillation. I'm going to shift gears now and talk a little bit about rate versus rhythm control. I think it's helpful to have some historical understanding there. This is the AFFIRM trial. So this sort of got us off on the wrong foot with thinking about rate versus rhythm control, but this is a randomized multi-center comparison. 4,060 patients total. They were randomized to either rate or rhythm control. Rhythm control, of course, is a heterogeneous group. Mostly this was amiodarone. Secondary use was sotalol. But really, this study found no difference in outcomes between these two groups. So mortality over 5-year follow-up was 24% in the rhythm control group and 21% in the rate control group. The only really difference they found was that there was more torsades in the rhythm control group and more hospitalization after baseline visit in the rhythm control group, which are certainly expected with starting some of the medications we use to rhythm control atrial fibrillation. So they concluded that they really didn't find any of the proposed benefits of rhythm control with this study. And I'll quote, the implication is that rate control should be considered a primary approach to therapy, and that rhythm control, if used, may be abandoned early if not satisfactory. So some key caveats or limitations to this study. Catheter ablation was certainly not at where, widely used. I believe 14 total in this study underwent catheter ablation for atrial fibrillation or atrial flutter. And certainly not using the techniques we use nowadays. Additionally, anticoagulation use was subpar in this study as well, or at this time, I should say. Warfarin was the anticoagulant of choice, and many of the strokes that occurred were when people were either off anticoagulation or had a subtherapeutic INR. So this led to an era where rate control was used more frequently. This is a study that again going back to the progression of atrial fibrillation. So this categorized, it looked at rate control versus rhythm control in terms of progression of atrial fibrillation. So all these people had new onset atrial fibrillation. And what they found is that if you start off with a rate control strategy, progression from paroxysmal to persistent is much more common than it is with a rhythm control strategy. So 27 or 28% almost in the rate control group versus 6% in the rhythm control group. And the predictors of progression from paroxysmal to persistent were atrial fibrillation at entry of the study. That was the strongest predictor. The second strongest predictor was whether or not the clinician chose to pursue rate control and not rhythm control. So fast forward to more recent data where we really have compelling evidence to think about rhythm control in patients. So this is the East AFNet study. This is a great study, 2,789 patients, recently diagnosed atrial fibrillation, so within the past 12 months. Very important, 30% of these individuals were asymptomatic, but nonetheless, they were randomized to either a rhythm control arm, which meant multiple different modalities. Again, flecainide was the most common. Catheter ablation was relatively uncommon initially, but that increased in how much it was used over time. And they compared that to standard of care, which was rate control, and followed these individuals over time and found that the composite outcome of death from cardiovascular causes, stroke, and hospitalization from worsening heart failure or acute coronary syndrome all were lower in those where they pursued early rhythm control. So key caveats and differences here, this study did include catheter ablation, and individuals were mandated to be on anticoagulation. So really we've come a long way in our management of atrial fibrillation. But again, studies like this would suggest that early rhythm control has a significant amount of value in terms of hard clinical outcomes for our patients. I'll jump into kind of, a discussion of how we control rhythm, medications or ablation. And we have good guidelines to recommend when to use atrial fibrillation ablation. So this is, any guideline reference I'll do is to 2023. That's the latest US AFib guidelines. But this was a cut and paste guideline recommendation from 2014 that we should consider it in individuals who have been intolerant of antiarrhythmics or have found them to be ineffective. And there's really good data to support these individuals do much better with catheter ablation than trying an alternative medication. I won't dwell too much on this data, but this is another randomized multi-center study that looked at individuals with atrial fibrillation who had failed one antiarrhythmic. They randomized them to ablation versus a trial of a different antiarrhythmic, and it's really striking the differences. 70% of patients treated with catheter ablation were free of recurrent atrial arrhythmias versus 19% in the individuals treated with drug therapy. So striking data there. But the 2023 guidelines now provide us with more evidence to support catheter ablation. So we now have a new Class 1 indication to consider atrial fibrillation ablation in individuals with symptomatic paroxysmal AFib who are, a bit on the younger side, perhaps, fewer comorbidities. And we know that in those individuals, AFib ablation may improve symptoms and reduce the progression of atrial fibrillation. So this is a nice study from the New England Journal of Medicine, 2021, looking at first-line catheter ablation for atrial fibrillation. So all these individuals had symptomatic, paroxysmal, untreated atrial fibrillation. 154 underwent ablation. They used the cryo balloon for this study to do the catheter ablation versus antiarrhythmic therapy in 101 patients. They followed atrial arrhythmias very closely. So everyone had an implantable loop recorder, and they followed these individuals for 12 months. And what they found is that any atrial tachyarrhythmia at 1 year, 43% in the ablation group versus 68% in the antiarrhythmic group. And in terms of symptomatic atrial arrhythmias, which I think we would agree that is quite maybe perhaps a more meaningful finding, 11% in those who underwent catheter ablation in that first year versus 26% on antiarrhythmic therapy. So certainly good evidence to consider catheter ablation as first-line therapy. We also know that catheter ablation has the possibility of delaying the progression of atrial fibrillation. So this is another randomized study, RF ablation this time, 128 patients versus antiarrhythmic therapy in 127. Primary endpoint was progression from paroxysmal to persistent atrial fibrillation at 3 years. What they found in this study was that individuals treated with radiofrequency ablation for AFib were 10 times less likely to progress from paroxysmal to persistent. So very good data to support this latest Class 1 recommendation for catheter ablation for atrial fibrillation. We also know that individuals with heart failure, AFib and heart failure with reduced EF, these individuals need a early and aggressive rhythm control approach. And catheter ablation is one modality that's been shown to help with these individuals. This is older data, but really compelling data. 179 patients, this is the Castle-AF study, but 179 patients underwent catheter ablation versus 184 who were in a rate or rhythm control. All of these individuals had an EF of less than 35%. All of them had an ICD. It was sort of a mix of ischemic and non-ischemic. In terms of the medical therapy, rhythm control was used less commonly than rate control. And they followed them for a median of 38 months. And you can see nice separation of the lines here in favor of ablation in these individuals. So the probability of survival, the probability of not dying and heart failure hospitalization, lower probability of those things in the ablation group. And when they did death from any cause, lower in the ablation group. Hospitalization from heart failure, again, lower in the ablation group. And I mentioned all these individuals had implantable defibrillators. So, really nice data in terms of how much atrial fibrillation they were having. So at 60 months follow-up, the ablation group, the mean percentage of atrial fibrillation was 27% versus in the, pharmacologic therapy group, 64%. Just to summarize that rate versus rhythm discussion, there's really a number of considerations that I would suggest you take into account when considering, is a patient appropriate for rate versus rhythm control. Certainly the patient's preference is key in that discussion, listening to them, listening to how they've reacted to different medications. Younger individuals, less comorbidities, certainly you would favor considering a rhythm control approach in them. Shorter duration, again, that goes to the East AF-NET study. Symptoms, we know we can improve quality of life with things like catheter ablation. For the sake of time, I can't show that data, but certainly it's there. LV dysfunction, I just showed you some nice data there to support rhythm control. And then smaller left atrial size tends to be more amenable to rhythm control as well. And all of these factors are essentially the exact same factors that I think about whether or not I want to recommend catheter ablation for a study or for a patient. It's really all of these factors would support that consideration as well. So now, again, shifting focus a little bit and getting more into the nitty-gritty of catheter ablation. This is another historical reference, but it's really a great one. The reason we do pulmonary vein isolation, at least in part, goes back to studies like this. So this is a study from the 90s, Dr. Hassegier, where they looked at triggers for atrial fibrillation. And they brought individuals to the lab who were having frequent atrial fibrillation, 45 patients. They put catheters into multiple parts of the heart. And what they found is that most atrial fibrillation, the earliest electrical activation, is in the pulmonary veins. You can see that by all these black dots on the right side of the figure here. Specifically, 94% of the patients had their earliest activity in the pulmonary veins, 2 to 4 centimeters deep into the veins. And so this is seminal work, and again, really shaped our field. It's a beautiful finding, and it's shown so simply on a black and white drawing. Well, we've progressed quite a bit with our technology, so we can show this with much more higher fidelity. So this is a case. This was actually this kind of late summer. I had the great privilege of working with one of my colleagues, or observing him during one of his procedures, Dr. Zacabe. And this was a patient that he was doing an AFib ablation on. So 57-year-old man, history of paroxysmal AFib, who had a prior ablation a few years ago, pulmonary vein isolation and CTI ablation for flutter, who was having recurrent AFib. And so came back to the lab. This is his initial voltage map prior to any ablation. So you can see, again, red would be low voltage, purple, just for the sake of simplicity, higher voltage. You can see evidence of prior left-sided, pulmonary vein isolation with some focal firing in the posterior carina. But you can also see the right-sided veins are largely reconnected here. So after Dr. Zacabe did ablation here, touching up the carina, and then touch-up lesions on the right-sided veins, he remapped and just had an outstanding result here. So these veins are completely isolated with clearly well-demarcated red versus purple here. And so at this point in the procedure, we do induction maneuvers, we start isoproterenol, things like that. As Dr. Zacabe was moving the catheter around, we had a very nice finding here. So I realize not all of you look at electrograms on a daily basis, but this patient's in sinus rhythm. The green is the coronary sinus signal, and the white here, this is the surface electrogram. So you can probably make out the P wave, you can certainly make out the QRS. And the splines of this multi-polar catheter that are on the posterior wall of the left atrium are showing electrical activity that's very coordinated with the coronary sinus, versus the splines that at this point are within the pulmonary vein, deeper into the pulmonary vein. Those are showing sort of chaotic, fast firing. So again, this individual was having recurrent atrial fibrillation, had right-sided reconnection during this repeat ablation, and clear focal firing from the right superior pulmonary vein. Just for the sake of this talk, I looked this patient up on Friday last week. They're doing outstanding. So a really excellent result, and I'm really happy that and fortunate to have such excellent colleagues like Dr. Zacabe to learn from. I'm going to eventually get to pulse field ablation, which I think we're all interested in, but I really want to lay some groundwork and just talk a little bit about RF ablation. You know, when you're doing radiofrequency ablation, in terms of the biophysics, you're applying current at the tissue tip interface of your ablation catheter. And you get two elements of thermal heating here. So the first is resistive. This is sort of a thin superficial layer. And the second is conductive. So this is more time-dependent, you know, a deeper lesion that's created. And once the tissue reaches 50 degrees, that's when you get irreversible damage. So we've learned over time that we can, you know, titrate our powers to sort of favor resistive versus conductive heating. So for instance, high power short duration is one of the more common strategies you use, particularly on the posterior wall of the left atrium. This is, gives favoritism to resistant heating, again, because that conductive is more time dependent. And so you should get more of a shallower lesion and theoretically be safer on the posterior wall. This is just a brief example of what let's see if I can get it to play. You know, an RF lesion set may look like. These are high power short duration lesions on the posterior wall, and then wrapping around the anterior wall are more traditional power used for longer duration to you know, eventually create pulmonary vein isolation. And you know, we've gotten better and better at this over time. So this is data from Dr. Melby helped publish this paper, and this includes patients from this institution. So this is a post-approval study looking at a specific ablation index and how that can contribute to outcomes for AFib. So they had 246 patients, all had drug refractory symptomatic paroxysmal AFib. And they used this, you know, sort of complex algorithm that looks at contact force of the catheter, power used, as well as time, and basically pumps out a number. And so they set numbers as goals and use those goals to see if reaching certain goals that would indicate a good lesion would increase the success rate of the procedure. And they had really nice findings. So at 12 months, in terms of freedom from documented atrial arrhythmias, with very stringent monitoring, it was 82%. So stringent monitoring was weekly trans-telephonic monitoring to start, spreading that out a little more as time went on. But if you're going by more standard of care, more, you know, intermittent ECGs, intermittent Holter monitors, and screening for symptoms, these individuals did great. So 93% freedom from documented AFib at the end of this study. And this was another figure from that study. You know, like I said, we've come a long way. So in 2010, I wasn't, you know, practicing electrophysiology, but we had non-contact force catheters at that time and a much lower success rate than we do now. So again, things have improved over time with radiofrequency ablation, but certainly there's been a, you know, much more of an interest in pulse field ablation. So this is, I show this because this is, you know, an article that patients are bringing into clinic. They're bringing up when they come for, you know, a cardioversion. But this was a Star Tribune article that featured a hospital in the southern part of the state and really brought to the patient's focus this idea of pulse field ablation as an option. So contrasting that with what I showed you for radiofrequency ablation. So with pulse field ablation, we have various catheter shapes. But essentially, you're exposing these cardiac cells to a high electrical gradient. This creates irreversible electroporation. It's a fancy way of saying there's permeability of the cell membrane, which eventually leads to cell death. And you know, really the key finding or the key hope with pulse field ablation was this preferential impact on myocardial tissue and, you know, sparing of other tissues such as the esophagus, things like that. And you know, to some extent that has played out, but we've certainly learned more as we used more and more pulse field ablation. And one concern with pulse field ablation is coronary artery spasm. So these top figures are from a porcine model. They used a catheter to apply pulse field directly on epicardial fat that was overlying coronary arteries. Certainly no one would advocate for that, but the finding is at least of interest. You know, you can see clear-cut spasm of both the RCA and the LAD in these images. And they found that these lesions penetrated up to 5.2 millimeters deep And when they did, histological sectioning of these coronary arteries, they did find changes. So there was some intimal hyperplasia, there was some tunica medial fibrosis. So, certainly not benign. In terms of real clinical practice, there have been, reports and observations about pulse field causing vasospasm with CTI ablation as well as posterior lateral mitral isthmus ablation. This was a study that looked at this, relatively low numbers, but using these sort of bigger pulse field catheters and doing mitral isthmus ablation. In this study, almost 40% had some degree of vasospasm. It was primarily non-clinical. It didn't create any adverse effects, and it resolved either with time or nitroglycerin. But nonetheless, pulse field does impact other tissues. Or has the potential to impact other tissues. So we have compared conventional thermal ablation to pulse field. This was a New England Journal of Medicine study that looked at Boston Scientific's Farapulse system compared to a group that either used cryo or radiofrequency ablation. They looked at the endpoint of freedom from initial procedural failure, documented atrial arrhythmias after 3-month blanking, antiarrhythmic use, cardioversions, or repeat ablation, and found that really, both modalities are reasonable options. So at 1 year, in terms of freedom from these events, it was 73% in the pulse field group and 71% in the radiofrequency ablation group. The Farapulse catheter is more of a one-shot PFA, so you can see it forming different shapes here. There's a basket and more of a flower configuration, and it sort of stamps on the pulmonary veins, and as you move and apply energy, you isolate the pulmonary veins that way. In terms of safety, relatively low number of events, which is I would say common for atrial fibrillation ablation. They did have 1 death in the pulse field arm. This individual had tamponade in the setting of a pericardial effusion and hemodynamic compromise that caused multi-organ failure, and unfortunately did die, but no atrioesophageal fistula, and really a low number of events otherwise, and not different between the two groups. I showed the previous few slides, pulse field being brought into the community and awareness in the community, and this is another great example of that. So this is Dr. Sengupta and the rest of, or several members of the EP lab staff, as well as other team members, being recognized as the first in the upper Midwest to use a novel system for both mapping and ablation. And so this is the Medtronic's Affera catheter. It is quite multifaceted, so it creates 3D electroanatomic maps as shown here. It also has the ability, this is called the Sphere 9 catheter. The Sphere can do pulse field ablation, so that, think about, again, on the posterior wall, this is an ICE image showing the esophagus. You can see how exquisitely close we are to the esophagus when we're ablating, but pulse field certainly has its advantage there. And then it also does radiofrequency ablation. This is an example, an ICE image of the cavo-tricuspid isthmus. You can see the distal RCA with these red arrows. So, having the ability to toggle between these two energy modalities, as well as do 3D electroanatomic mapping, is quite a unique feature of this catheter. And I'll just mention, from my standpoint, it's so inspiring to see, my colleagues like Dr. Sengupta, really being people that are sort of moving the needle in our field and doing these innovative therapies that we can provide to our patients. I also know that, Dr. Abdelhadi and others, a lot of behind-the-scenes work in terms of getting this modality available for our patients. So I really, I admire that, and I feel very grateful to be even a small part of that, or close to that. So in terms of this new novel catheter, first in human experience, it proved to be relatively safe, also relatively quick. 22 minutes in terms of isolating the pulmonary veins. They did pulmonary vein isolation as well as multiple other lesion sets. They actually advanced the catheter into the coronary sinus and performed pulse field there, which is not an approach I would necessarily recommend, but something they did nonetheless. And really vascular complications were the primary finding. A higher number than I would expect for most AFib ablation studies at 5.3%. One of those needed surgical repair, but it was actually on the contralateral side of the study catheter, so really not, I think, relevant to the catheter itself. They also did EGDs in 60 of these patients and found there was, in 2 of the patients, minor erythema of the esophagus. Hard to know what to make of that. It was not a clinically significant finding, but the possibility of some interaction between other tissues and the pulse field catheter. They've also looked at this catheter in terms of comparing it to our standard radiofrequency ablation. So this was a randomized non-inferiority trial where they randomized patients to undergoing ablation with the Sphere 9 versus the more standard Thermocool SmartTouch SF RF catheter, and looked at sort of a composite outcome of freedom from procedural failure, repeat ablation, arrhythmia recurrence, drug changes, and cardioversion, and found overall pretty similar rates in terms of freedom from those events between both groups. What was statistically significant was skin-to-skin procedural time was definitely lower, as well as other like energy application time, definitely lower when using a catheter that allows for both RF and PFA. And they, in terms of safety events there, really low incidence of events. I would say this is more typical for what we see with catheter ablation. A few patients had to be hospitalized for things like pulmonary edema or COPD exacerbation, things that may be related to the ablation procedure, but certainly things that are not life-threatening. They also looked at, just as an aside, brain MRIs in these individuals, a certain number of these individuals, and found silent ischemic lesions in 3 of the 27 patients that had the Affera catheter used, and 2 of 35 in the standard RF group. Now, several of these lesions in 2 of 3 patients and 1 of 2 in the control group resolved over time, and they weren't clinically significant. But again, these are indicators that potentially there's more improvement that can take place with these catheters over time. So it's really it's an exciting time to be an electrophysiologist. We have a lot of things to offer our patients. At the Minneapolis Heart Institute, we have FARAPulse, we have Affera, we have more catheters coming in the future, and so again, an exciting time. So just to summarize, the global prevalence of AF has increased substantially over the past several years. It's a progressive condition. I really want to impart that on you all. There's structural and functional changes that occur over time. Being able to interrupt that progression is critical. There's also a number of risk factors that we can modify that are also of critical importance. When thinking about rhythm versus rate control, it's valuable to take into account patients' preferences, to really listen to them. What are they feeling in terms of medication side effects and long-term preferences? Are they younger? Is the AFib shorter duration? Are they symptomatic? Do they have LV dysfunction? All those would be strong reasons to really consider rhythm control. And again, we have great data to suggest catheter ablation as a modality for rhythm control, specifically in certain patients, paroxysmal, younger, few comorbidities, and those with cardiomyopathy. And lastly, I'll just say that PFA is an evolving technology. It's quite promising. I think it has a little ways to go in terms of continued improvement, but it's available to patients here and something that we're certainly using more and more of. So that's all I got. These are my children. So thank you all. Yeah.
All right, Dr. Decker, thank you so much for that presentation. Thus far, we have 2 virtual questions. The first is from Dr. Olson, and he asks, on pacemaker checks, how much AF is enough to warrant anticoagulation?
So, my approach to that, and this is based on the guidelines, is that if someone's having more than 24 hours of atrial fibrillation, somewhat unrelated to this talk, but thank you, Dr. Olson. More than 24 hours, and their CHA SVASC is high. Those are the group that I see find value in anticoagulating. If it's less than 24 hours, it's more of a gray zone. That's a Class 2B recommendation to start anticoagulation, which I'm sure Dr. Olson knows. I appreciate his inquiry.
Sounds good. Thank you for that. So the second question comes from Dr. Lesser.
Yes.
So he says, wonderful, clear talk. His question is, how important are atrial tachycardias with possible subsequent degeneration to atrial fibrillation, a mechanism for atrial fibrillation initiation?
That's a great question. I don't know if I have a perfect answer there. I think in younger patients, we tend to see SVTs possibly triggering AFib. In terms of, it's going to vary from patient to patient. So in paroxysmal AFib, it's mostly the veins that are providing those triggers. As you become more and more, persistent, long-standing persistent, I think any sort of focal firing, scar, it tends to lead to substrate that allows for atrial fibrillation. So I would worry about that more in the persistent and long-standing persistent patients. But in terms of paroxysmal, I think the pulmonary veins are the primary driver. Yeah.
Seeing no one else speaking up, thank you.
Yeah.
Excellent, very clear and exciting.
Thank you.
After a successful RF or pulse field ablation procedure, our patients remain on, sorry about this, another anticoagulation question. They remain on anticoagulation.
Yeah.
When do we judge that that procedure was permanent enough to say, because it's a high priority for almost all patients to get
Yeah.
off their Eliquis or their
Yeah.
Xarelto, when do we make the call and say, okay, it's been X amount of time?
Yeah.
And I know my answer, but I wanted to know what yours is too.
The way I look at AFib ablation is our goal is not to abolish atrial fibrillation. It's to take the burden and markedly reduce it. So I always set that standard or that expectation with patients where we're not going to cure this, we're going to reduce the amount you have. That being said, if someone meets the indication for anticoagulation, I don't use an ablation to decide necessarily whether or not to anticoagulate them in the future. But it's a very interesting question. I don't have a great answer there in terms of what the actual burden would be. We know with flutter, if we're able to ablate flutter and not find any atrial fibrillation, those patients can come off anticoagulation, or at least be considered to come off if it fits with their preferences. But in terms of atrial fibrillation, the goal of the procedure is to reduce the amount, not to make it fully go away. So I don't have a great answer in terms of when it's appropriate to stop.
That was a good answer, actually. I think that it means you can never stop anticoagulation in most patients.
Yeah.
Despite the fact, forgive me if I'm sounding inflammatory here, but despite the fact that we have so many ways of monitoring for AFib now, clinical, of course, and wearables and fairly reliable apps and things like that. If I have a patient who had an AFib ablation procedure and is a good patient, some are, and is a self-monitoring patient that will be able to tell quite reliably if they have AFib again, shouldn't I stop anticoagulant in that patient?
I saw a patient recently in the hospital who had an ablation over 10 years ago at an outside institution. We didn't have the records, ablation for AFib, and had no AFib since that time. He was not on anticoagulation. And honestly, someone like him, it's harder to know what to do. He didn't have a high CHADS-VAS score, when he first did the ablation. He did at the time that I saw him. But in someone who's had no AFib and been monitored for over 10 years after an ablation a long time ago, I don't know if I can make a strong case for anticoagulation in them, but it's one of those things you sit down and you talk to people, find out what their preferences are, and then make a shared decision.
I'd love to comment on that question, and I think it's a great question. I think we should ask that question again in a year, and again in a year after that. Also, here's why. We are watching. It's like asking, is it going to be a sunny day before the sun comes up? It's like you're going to find out that answer soon, but we're watching the evolution of this procedure, and we're gaining understanding of the mechanism of atrial fibrillation. The Hasegaard paper from 1998 demonstrated that the triggers for atrial fibrillation are primarily in the pulmonary veins. And you can go to the heart and induce AFib just by rapidly pacing in the pulmonary veins in people with AFib and not in people who don't have AFib. And then you can isolate the pulmonary veins, and you can put your catheter right back on the posterior wall, pace the atrium at 300 beats a minute, and it won't fibrillate anymore. So part of it is excluding that border zone tissue that is arrhythmogenic in those patients. And what we've seen with catheter ablation, as our understanding and our technology improves, is we improved our success rates in mitigating atrial fibrillation, not eliminating it completely. But we haven't had a modality that permanently and reliably isolates the pulmonary veins until just this year. So I think when we saw that patient in 2020 that had an ablation, we brought them to the lab and mapped and saw, well, yeah, they have recurrent AFib, and their right superior pulmonary vein is firing independently on its own, and it had recovered probably a month after that procedure, whenever they had that in 2020. So that's a patient who had an ablation, had recurrent AFib. You wouldn't want to take them off therapeutic anticoagulation, but give them a year after a definitive procedure that definitively isolated their pulmonary veins and excluded those initiators, and not a hint of AFib. You know, that's where we've mitigated the initiators, we've prevented retraining of the atrium to fibrillate. You know, we've prevented that progressive disease. And unless they have some other myopathy and mitral valve disease and other problems that are causing changes in the left atrium, that may be someone who gets to safely stop atrial fibrillation. And I would just add, we have patients now who are using wearable devices to monitor for atrial fibrillation continuously. And there's a clinical trial that's running now out of Chicago using a special algorithm on a wearable device, on a watch, smartwatch, to detect atrial fibrillation and warn the patient with a vibration and a text message and a phone call and a call center calling them to say, start your anticoagulation. Continue it for a month. The device will continue to watch for AFib, and if there's no more AFib, they can stop. And it's going to be, I think, a hybrid of all of these new technological innovations to allow us to determine who can avoid the risk of continued therapeutic anticoagulation. I mean, you take somebody who's cycling out on the road in Minnesota, with the ice and the drivers, lots of risk, and give them and commit them to daily anticoagulation forever. They're going to have a bleeding event at some point. They're going to crash their bike and have a bleeding event. They're going to fall down the stairs. They're going to fall on the ice and have a bleeding event. And if they didn't have atrial fibrillation, did we really help them? By giving them anticoagulation without mitigating ongoing stroke risk in the absence of recurrent AFib. So I think that's a question we need to continue to ask, and we're going to get an answer eventually about how to manage the competing risk of daily anticoagulation for people who have extremely rare or no more AFib after ablation.
Yeah. Dr. Singleton.
Great presentation, Joe. I thought that it was fantastic how your research on adiposity and atrial myopathy kind of goes to the crux of AFib and the development of AFib with the atrial myopathy, and how you set AFib ablation as one of those factors that can delay the progression of the atrial myopathy or halt atrial myopathy. I was interested in your thoughts about what other factors and new interest, whether you've heard anything about GLP-1 agonists and other factors that are available to us now that could also be full court press to help prevent that atrial myopathy from forming, and what opportunities lie in that realm in addition to AFib ablation.
Yeah, that's a great question. So I know bariatric surgery, there's data there that can reduce weight and potentially impact AFib The GLP-1s, I don't know the data there. I don't know if we have it. Where I find trouble there is, I think the cost of the medication and patients' ability to take it from that standpoint. But I think down the road, that would be anything we can do to help people lose weight will have a huge impact on AFib burden. So it's something I've thought about, but every time I recommend it or talk to a patient about it, they've considered it with their primary. There's some financial issue or some other issue, and so I think we're early in the stages of those types of modalities. But yeah, lifestyle modifications are huge. Alcohol is another big one. There's a great New England Journal of Medicine randomized trial that looked at reducing alcohol intake and reducing AFib burden. There's really a number of things we can do and talk to our patients about. Go ahead.
Oh,
Well, either one, yeah.
okay, amazing presentation, Dr. Decker, thank you. My question is, usually people, especially in their late 70s or 80s, no symptoms, structurally and functionally normal heart on echo, some paroxysmal or sometimes even persistent AFib, but they're not that much bothered. When do you exactly say, like, this is a time I would recommend rhythm control in terms of like early rhythm control strategy? Otherwise asymptomatic and functionally normal heart.
That's a great question. So it's harder to say in that circumstance. If you really talk to patients, one of the things I always try to get from them is, think about a time when you were in atrial fibrillation and then post cardioversion or post some type of rhythm control strategy. Think back then, and did you feel any difference? Fatigue, shortness of breath, there's all these symptoms of AFib. Usually you can garner some symptoms. If patients are truly asymptomatic and they've been in AFib for, or they've had intermittent AFib for a long period of time, it's harder to say, because I think the data would suggest if it's within the first 12 months, those individuals benefit. If there's LV dysfunction, those patients benefit, symptoms benefit. But in someone who's truly asymptomatic, which I think is relatively rare, it's harder to make an argument for rhythm control. But again, I think you try it. I think medications are quite valuable in that setting. Try sotalol, something like that, for a short period of time. Give them freedom from AFib, and then see them again in 3 months or 6 months, and see if they feel better. And then you move on to ablation if need be. So.
And a quick question. Thank you so much for your presentation.
Yeah.
What is the current evidence of combining catheter ablation and left atrial appendage occlusion?
There is a new study. I don't know that data intimately, but I think Dr. Sengupta obviously does. But that is an emerging dual procedure that we're doing. I honestly can't speak directly to that, but I don't know if Jay, you have any insights there.
It's something that we are doing, and it's going to be evolving, right? It's early now in terms of doing Watchman, but it makes sense, for patients who are. Our approach is that if patients are a good candidate for Watchman to begin with, and they need an AFib ablation strategy, then they're good candidates for the concomitant. In this option study that was published, they had patients that were not necessarily would meet standard indication for Watchman, and they did have good results with both ablation and Watchman. But in general, as Dr. Decker mentioned, with anticoagulation, we do feel that that's still the gold standard. So our approach is we will do concomitant procedure, but they really still have to be candidates for Watchman and not be candidates for long-term anticoagulation. So Watchman is an alternative for them. And then we do have good results in our institution, both here at United with concomitant AFib ablation and Watchman implant.
Yeah.
I work with post-op open heart surgery population, and we have get the atrial fib a lot.
Yeah.
So it was, metoprolol, and they went through a phase where everybody's on a diltiazem drip. Now, the last few years, it's been the amiodarone drip protocol, but you get a lot of infiltrations from that, and it's quite painful for patients. So from a nursing perspective, is there anything new or different outside of the amio drip that would be helpful? Please tell me yes.
Yeah. No, unfortunately. I think the guidelines would say rate control is the go-to there, but we use a lot of amiodarone in that setting. I wish I had better solutions for you. But acutely rate control, long-term rhythm control, usually they're on amiodarone for about 3 months, but in the hospital setting, we're somewhat limited. And as you said, we see this quite commonly. So almost 50% of patients, or up to 50% with open, chest surgery can have atrial fibrillation. So if someone came up with a good strategy there that didn't cause other issues, that would be great. But we're kind of limited to rate or rhythm control, and amiodarone is kind of the go-to in that population.
There was a time when we did a lot of beta blocker pre-op,
Yeah.
and I don't see that as much anymore, so
Yeah.
was that just that it doesn't work, or?
I think there's data to suggest amiodarone preoperatively has value, but beta blocker, to my knowledge, there's a lot of considerations there. If you're taking someone for an invasive surgery that could cause hemodynamic compromise or RV dysfunction after, beta blocker could be problematic. But amio is such a plus minus. There's so many side effects. There's such a high risk profile ongoing with that medication that it's hard to take all the plus and minuses there. But pre-op amiodarone has been used. Yeah.
All right, so I know we're at time. We do have 3 more virtual
As long as they're not from
questions.
Dr. Olson.
None from Dr. Olson, but the first is actually from Dr. Cavalcante, who says, excellent talk. Can you please also comment on the interplay between AF and TR progression? Would those patients benefit from rhythm control?
These are great questions. Truly great questions. I don't know if there's strong data there, but from an observational standpoint, I think controlling the rhythm can improve valvular lesions like tricuspid regurgitation. I've certainly heard that anecdotally and seen that anecdotally. I don't know if there's strong data to support that, but I think again, reducing that progression that I showed is what's critical in these patients, because they will progress. Any way we can get in front of that and stop the left atrial dilation and the other changes can have value beyond just cardiac structure and function, valvular function as well.
Thank you. All right, so the second is from Dr. Dasuki, and she says, thank you for your insightful presentation. You mentioned that obesity contributes to atrial myopathy. I would like to know your perspective on whether obesity could also have an impact on genetic cardiomyopathies as well, like ARVC or LVNC.
I think certainly that's getting very nuanced there, which I don't say I have data to support any insights there, but the way that obesity impacts the heart is that it's really a cascade of events, like I mentioned, that involves increased cardiac output, more circulating blood volume. But beyond that, there's all these other issues with obesity, in terms of contributing to other comorbid conditions and things like that. So I can't specifically comment to those less common genetic cardiomyopathies, but in general, I would say that avoiding obesity, is going to have beneficial impacts from a cardiac structure and function standpoint, which would certainly benefit all populations, including the genetic cardiomyopathy.
Thank you for that.
Yeah.
So the last virtual question comes from Marcus, and he asks, any views on being more open to ablate in pace to treat the AF irregulopathy?
There's good data there. The way I approach pacemaker AV node ablation is, really patients later in life, they have comorbid conditions, they've had. You look at, I look at the CT scan, look at the echocardiogram, does their left atrium look like it has the possibility of any chance of sinus rhythm? If it does, I like to give it that chance. But if things look like they've gone too far, someone's been in AFib for 10 years, they clearly don't like the medications they're being on for rate control, those are patients that I certainly lean on that strategy for. There's also some data to suggest that that strategy may be helpful in reducing heart failure hospitalizations as well. So it is a modality. The way I was trained is to think about ablation first and find a way to do rhythm control. So that's what I tend to do, but certainly ablate pace has its place in our practice.
Thank you very much.
It's an excellent talk. So my question is, how do you decide the different technique? You mentioned different techniques such as radiofrequency ablation, pulse field ablation? Like, how do you decide to perform which technique to which patient?
Yeah, great question. So I think what our practice is focusing on is that paroxysmal atrial fibrillation, where you're thinking that isolating the veins is really going to be the goal, and you may not need to do anything else. Those are patients that are really amenable to that FARAPulse catheter, the kind of, for lack of a better term, the one-shot approach. But if someone has, persistent, they've had AFib for some time, you're worried you're going to also be doing some linear ablation, so CTI ablation, mitral isthmus ablation. I think that's where the Affera system is really uniquely positioned to be quite valuable, because we often find ourselves doing, not only those linear lesions, but also perhaps a roofline, things like that. So, having a catheter that does both, in my mind, is the best strategy, because then you're in the procedure and you can make those game time decisions without pulling out new equipment. But it's nuanced, and it has a lot to do with the atrial myopathy, the substrate going into it. So, thank you.
All right.
Thank you very much.